Rounds. So we are very happy to have Betty. Betty, of course, does not need much introduction, but now she's in a new place, so we will have to introduce her officially. She has been here for quite some time. She graduated from medical school in the Philippines, did her residency in New York and her fellowship at Emory. And she was there in Emory for 10 years, where she did interesting research identifying new protein on insulin signaling, which she named Sensitin, and subsequently worked on the same thing here with NIH-funded research. She came to Louisville in 2003 and stayed here until just about 4 months ago, or well, 3 months ago, when she decided to move to beautiful Owensboro, where she's currently an endocrinologist. We all know her very well. She's a very smart and excellent clinician, scientist, and also a wonderful teacher, and known for clarity of presentation and the depth of topic that she goes into depth on these topics. And we're very happy to have her talk today about Cushing syndrome and who should be tested. So take it away.
Okay, thank you very much. Can you hear me, all of you? Okay.
Yes.
So I'm going to mainly focus on Cushing's disease, but just in general, I will review the topic. Okay, just a second. Okay. Hopefully, we're going to look at the clinical presentations of patients that should raise the index of suspicion for Cushing syndrome, review the prevalence, diagnostic criteria, and differential diagnosis of Cushing syndrome, and discuss the treatment options available in terms of medical, surgical, and radiotherapy. I have nothing to disclose. We all know that Cushing syndrome is not a common disease. It's estimated that the prevalence is 13 cases per million individuals. The most common is Cushing's disease, or ACTH-dependent Cushing syndrome. It consists of 70% of the cases of Cushing syndrome. Ectopic ACTH secretion is found in about 10 to 15% of patients with Cushing syndrome, and primary adrenal tumor occurs in about 15 to 20% of the cases. It's a predominantly female disease. The female to male ratio is 5:1 for both adrenal or pituitary tumor. But ectopic ACTH production is more frequent in men because it's usually associated with lung tumors in this population. In terms of, I'm just going to mention briefly ACTH-independent Cushing syndrome, or adrenal Cushing syndrome. 90% of the adrenal causes are due to unilateral tumor. 60% are benign adenomas, and 40% are carcinomas. In terms of adrenocortical carcinoma, in about 60% of the cases, they present with secretory syndrome. 65% are mixed or pure cortisol secreting tumor. And PPNAD, primary pigmented nodular adrenocortical disease, and the macronodular adrenal hyperplasia is a completely separate topic that we could explore in the future. Okay, I think all of you have seen this patient because I have sent her to Louisville to be operated by Dr. Williams. She is a 27-year-old female who was originally referred for uncontrolled type 2 diabetes mellitus. She tells me that she has hypoglycemic symptoms while she was in high school, with blood glucose going down to the 30s. And then 8 years ago, at age 19, she had gestational diabetes, which was controlled by diet alone. And 3 years ago, she was found to have hemoglobin A1C of over 7%, was referred to another endocrinologist who started her on metformin, 1 gram BID. The reason she came to me is because her friend, who is a nurse, told her to come and see me. She complained of weight gain of 16 pounds in 1 year, even though she's very religious about her diet. She said she's stick to 45-gram carb per meal and 15-gram carb per snack. And she feels very hungry all the time, has low energy level, and has exertional dyspnea. Her A1C was 8.3%, so it's not too bad, and yet she's having all this polyuria, polydipsia, nocturia 3 times a night. Her family history is really not helpful. All she said is her maternal aunt and her grandmother have pre-diabetes. Nobody has diabetes in the family. She also has a regular menstrual period. She was amenorrheic for 3 years while on Nexplanon. While still on Nexplanon, she had 2 months of continuous vaginal bleeding, so the Nexplanon was removed. After it was removed, she had regular cycles for a few months, and then by the time she came to me, she was amenorrheic for 44 days. She also has new onset hypertension with heart rate running in the 120 to 130s. And her blood pressure when I saw her was 146/100 while taking chlortalidone, lisinopril, and carbidiol. These were all added within a week by the cardiologist. She never complained of headache until her second visit when I told her that her cortisol level was high. And she had frontal headache, and then nape pain between the scapula, shortness of breath. She has +2 pedal edema. She does not have hemianopsia, but she said her vision is kinda off. She has seen the eye doctor twice already for this. And this is her physical exam, okay? She looked very flash, okay? Her BMI was 22. So she looked at me and showed me her belly and said, "Look at me. I look like I am pregnant." And I was surprised because her BMI was 22. And she has very thin legs and thin arms, okay? And you can see that although it's not purple looking, her abdominal tray is kind of wide, you know. She did not tell me until later that she had paid $3,000 to have cool sculpting to remove her fat, and it was never successful. She did not lose any abdominal fat from that procedure. On day 1 that she came to me, I told her that there's something else going on. You do not have strong family history of diabetes. You may have secondary diabetes. At 3 o'clock in the afternoon, her random serum cortisol was 20.85 microgram per deciliter, and her ACTH was 95.9 picogram per ml. I also did irregular menstrual cycle workup, and her DHEAS was elevated at 575 microgram per deciliter, and her testosterone was actually normal. It's something like 30 nanogram per deciliter. Her 1 milligram overnight dexamethasone suppression test showed non-suppressed AM cortisol of 20.85 microgram per deciliter, even though the Endocrine Society consensus statement discouraged the use of 8 milligram overnight dexamethasone suppression test. I did it anyway, and she did suppress some to 8.26 microgram per deciliter. So she's a very compliant patient. You ask her to do something, she'll do it right away. So we did 24-hour urine-free cortisol 1 week apart, and her first one was 481.3 microgram and has good creatinine level. And the second one was 591.3 microgram, but in this case, it's a little clouded because she has high urine volume. And she told me she has all this polyuria, polydipsia, and she has to ask for a second container in the afternoon. But her creatinine also showed she has complete collection. So the next step was an MRI of the pituitary gland. Thank God there's something there so that she does not have to go through inferior petrosal sinus sampling. And she had an 11 millimeter by 7 millimeter by 9 millimeter lesion in the pituitary gland. And then I did I don't know why it was called microadenoma. I guess it's very, borderline. And she had chronic microvascular signal changes of the posterior periventricular white matter that is premature for age. So I'm sure Dr. Moksha Gandum has seen this patient. She underwent transsphenoidal ademectomy, and her next morning cortisol is 4 microgram. Now, this lady, I just saw 6 days ago. Again, very different presentation for Cushing syndrome. She is a 49-year-old lady who just mentioned while having routine gynecologic exam that she had increased chin and sideburn hair for a year. So the gynecologist is apparently very conscientious because she then measured the total testosterone. It's so unremarkable that I may not do it myself, she complained to me. Her total testosterone was 447 nanogram per deciliter with FSH of less than 0.3 milli-international unit per ml, micro probably. And the gynecologist called her on the same day of receiving the testosterone level and did a vaginal ultrasound which was negative for ovarian mass. Her history is she used to birth control pill from age 17 to 28 years old, except for the time that she conceived her 2 children. Then she stopped using birth control pill in 1999 because her husband had vasectomy. She became amenorrheic in 2011 after uterine ablation for dysfunctional uterine bleeding. So, of course, the husband is always a suspect. So, the husband used testosterone cream and gel between 2015 and 2016 and also received testosterone pellet injection in 2016. but that was only one time according to her. And she used Nair every other day to remove her chin and sideburn hair. She has increased libido. Her voice is as if, she said, it's like as if I'm smoking. But she does not have hair growth anywhere else in her body, even by physical exam. Her scalp hairline is unchanged. She has lost 5 pounds in the past 1 month because of intermittent fasting diet, and her BMI is 22.66. The only complaint she had is she has insomnia. She does not have change in her breast size. The only past medical history she had is she had urethral strictures since she was 4 years old. So she required every 6-month dilatation since childhood. If she missed one for a week, she will get UTI. She also has chronic migraine headache and is using Maxalt PRN. So her initial blood test showed her ACTH is suppressed. Her serum cortisol, however, is high. Her FSH and LH are suppressed, and her estradiol level is pretty high. Total testosterone is elevated at 437 nanogram per deciliter. Free testosterone is in the 80s. Androstenedione is 3,986, so very high. DHEAS is 1,141 microgram per deciliter. Because she has hypokalemia of 3.2, I also did Aldo and Renin, which is pending. Because her ACTH is suppressed, I did a 1 milligram overnight dexamethasone suppression test, and her AM cortisol is 12.62 microgram. The reason I'm presenting this is she's going to have surgery probably next week, and we'll probably do it at Norton. Okay, MRI. It's a 8.4 by 8.4 by 6.5 centimeter right adrenal gland mass with central necrosis. It's abutting the right lobe of the liver, but not clearly invading the liver. It also has mass effect upon the inferior vena cava, with no definite invasion of the inferior vena cava. So they're not sure whether it's invasive. I just ordered, but the right hemidiaphragm is stented, so it may have invaded that area. So I just ordered a CT scan of the chest today to see if it has, Anyway. So these two patients have very different presentation. If you see these patients, she does not have any Cushing's manifestation at all. She does not have not even an ounce of fat in her abdomen. She looked very tan, and I asked her, why are you very dark? She said she spent a lot of time on her lake house, so she's exposed to the sun a lot. Anyway, on the recommendation of the consensus meeting by the Endocrine Society in 2008, they recommended who should be tested for Cushing's. They said that make sure that you have a complete drug history to exclude exogenous glucocorticoid exposure that leads to iatrogenic Cushing syndrome. And The people that needs to be screened are the people with unusual feature for age, like osteoporosis and hypertension, which applies to my 27-year-old patient, or patients with multiple and progressive features, particularly those that are more predictive of Cushing syndrome. We're going to go through that. Children with decreasing height percentile and increasing weight, patients with adrenal incidentaloma compatible with adenoma. They recommend against widespread testing for Cushing syndrome in any other patient group. So what are the features that best discriminate Cushing's patient from just obese patient? Easy bruising, facial plethora, proximal myopathy or proximal muscle weakness, striae, especially if reddish purple or over 1 centimeter in width. In children, weight gain with decreasing growth velocity. And what are the features that should not make you work up the patient for Cushing's, because it's very indistinguishable from ordinary obesity? The presence of dorsocervical fat pad or buffalo hump, facial fullness, obesity, supraclavicular fullness, thin skin, peripheral edema, acne, hirsutism or female balding, and poor skin healing. In children, abnormal genital virilization, short stature, or pseudo-precocious puberty or delayed puberty should not be a reason to screen for Cushing's. There is a study showing what features that are more specific for Cushing's compared to, the general population with obesity. These are the likelihood ratio. They show that osteoporosis is more specific to Cushing's, followed by muscle weakness, ecchymosis, hypokalemic alkalosis, central obesity, hypertension, hirsutism, but not, glucose intolerance, oligomenorrhea, and generalized obesity. So osteoporosis and muscle weakness is particularly important. Again, the classic features that we discuss about Cushing's are they have rosy cheek, moon phasie, fat pads, thin skin, thin arm and thin legs, high blood pressure, pendulous abdomen, red striation, bruisability and ecchymosis, poor wound healing. As you can see, this applies to my first patient who has Cushing's disease, but really does not apply to the second patient whose BMI is 22, does not even have one feature of Cushing's that I can find, Okay, we know that the Cushing syndrome has multi-system morbidity that we need to pay attention to, including changes in body composition like osteopenia or osteoporosis. They may present with neuropsychiatric disturbances like depression, psychosis. In this patient that I had, the first case, she had insomnia. Endocrine changes include secondary hypogonadism, secondary hypothyroidism, which the first patient has because her free T4 was 0.64 or something like that. She had hyperandrogenism. Her DHEAS is elevated. She had central obesity, hypertension, diabetes. I did not check her lipid. But seems like every time she tells me she's swollen somewhere or she's having tachycardia, I have to do PE work up all the time. And, she D-dimer. And the other day, we have to do, venous Doppler to rule out DVT on her. And then mineralocorticoid effects, including hypertension, edema, hypokalemia. Hypokalemia was present in the lady with adenocarcinoma. Infection, opportunistic infection, and nephrolithiasis are also part of the complications of Cushing syndrome. The workup generally is you do two of these, either 24-hour urine-free cortisol level, overnight 1 milligram dexamethasone suppression test, late night salivary cortisol, or 48-hour 2 milligram dexamethasone suppression test to rule out pseudo-Cushing's. So anytime you have abnormality, you need to confirm it with another test. And after you confirm they have Cushing's, that's when you're supposed to measure ACTH level. In terms of 1 milligram dexamethasone suppression test, it's given at 11 p.m. or 12 midnight. If it's given at 11 p.m., if it's taken at 11 p.m., you measure the plasma cortisol at 8 a.m. If it's given at 12 midnight, you measure the plasma cortisol at 9 a.m. And of course, the plasma cortisol should be less than 1.8 microgram per deciliter. The old cutoff value of 5 microgram per deciliter is not being used right now. And you have to exclude patients who are on estrogen. It depends on the sensitivity and specificity of this test is dependent on the weight of the patient. In this study, they showed that in lean subject, when you do the 1 milligram suppression test, dexamethasone suppression test, the sensitivity is 98.1% and specificity is 98.9%. If you combine the lean and the obese subject, the specificity goes down from 98.9 to 89.5%. If you do the 1 milligram dexamethasone suppression test in obese subject, the specificity go down further to 80.5%. Of course, you have to, patients who are on various seizure medication, a lot of the HIV medication, you have to, even pioglitazone can accelerate dexamethasone metabolism by cytochrome 3A4. So some people do measure, dexamethasone level the next day. That drugs that increase cortisol binding globulin may falsely elevate serum cortisol like estrogen and use of mitotaine. And there are drugs that will increase urine-free cortisol, remember, is including fenofibrate and carbamazepine, some of the synthetic glucocorticoids. So in terms of screening, the Endocrine Society has the following recommendation. If a patient is pregnant, they recommend using the urine-free cortisol against using the 1 milligram dexamethasone suppression test because urine-free cortisol is not affected by cortisol binding globulin. In patients with epilepsy, because all the anti-epileptic drugs can increase the metabolism of dexamethasone, they recommend not using the dexamethasone suppression test. Instead, use the salivary cortisol or urine-free cortisol measurement. In patients with renal failure, the urine-free cortisol will be abnormally low, so you use the 1 milligram overnight dexamethasone suppression test. In patients with cyclic Cushing syndrome, in which you suspect they have cyclic Cushing syndrome, it's best to do the urine-free cortisol or midnight salivary cortisol. In patients with adrenal incidentaloma, because of the lack of sensitivity of urine-free cortisol measurement, they suggested that instead of using urine-free cortisol measurement, you should do the 1 milligram dexamethasone suppression test or late-night salivary cortisol measurement. In terms of urine-free cortisol, it should be 3 to 4 times the upper limit of normal. In this case, the patient I saw was pretty high. It's 10 times the upper limit of normal. If there's 3 negative urine-free cortisol measurement, that will exclude, Cushing syndrome, except for the incidentaloma. You need to do at least 2 collection of the urine because sometimes it's very variable, and the instruction on how to collect the urine for urine-free cortisol measurement, and you need to measure the urinary creatinine at the same time. So, that 10% of the serum cortisol is unbound and is physiologically active, and cortisol is mostly bind to cortisol binding globulin, but not the free cortisol segment. And 1% of urine cortisol is secreted unaltered in the urine, and majority are reabsorbed by the tubules. So the sensitivity is quite low. It's 45 to 71% for this test, but it's very specific. Men were 1.3 times more likely to present with abnormal urine-free cortisol than female. And as you get older, the odds of abnormal urine-free cortisol decrease by 10% for every 10 years in age increase. And the higher your BMI will be, the lower the urine-free cortisol will be. And if the creatinine clearance is less than 60 ml per minute, then you more likely will get falsely low urine-free cortisol measurement. And the LCMS and separation by HPLC is what is usually used now, and then you do after you separate it, you then do the RIA or ELISA. It's not enough to detect mild or subtle autonomous cortisol secretion. Salivary cortisol is collected between 11 p.m. to 12 midnight by passive drooling or by placing a cotton pledget in the mouth and chewing for 1 to 2 minutes. The sample is stable at room temperature or refrigerated for several weeks. They use an ELISA or LCMS assay, and the cutoff is usually less than 145 nanogram per deciliter. It's apparently very sensitive and very specific. And you need at least 2 measurements of this, like the urine-free cortisol measurement. The 2 milligram dexamethasone suppression test is being used to distinguish it from pseudo-Cushing, real Cushing from pseudo-Cushing. And dexamethasone is given as 0.5 milligram every 6 hours, beginning at 9 a.m. and then every 6 hours for 2 days. And then you measure the plasma cortisol 6 hours after the last dose of the dexamethasone. And the cutoff value is the same, less than 1.8 microgram per deciliter. You do not have Cushing's, and the sensitivity is 98% and very specific. When the Cushing syndrome is confirmed, that's when you're supposed to measure ACTH level. It's actually very inconvenient not to measure it together. Because, for example, I work in a satellite clinic. Every time I order ACTH, the patient has to drive 2 to 3 miles to the hospital to have it drawn. The reason for that is they have to spin it immediately and then freeze it. So the satellite clinic do not do it, you know. So if ACTH level is suppressed less than 5 picogram per ml, then you have an adrenal source of Cushing's. If the ACTH is not suppressed or more than 15 picogram per ml, then you have to look into the pituitary gland. If ACTH level is between 5 to 15 picogram per ml, you just disregard it according to them. So, when you have the plasma cortisol of ACTH of less than 5 picogram per ml, you need concurrent serum cortisol measurement to diagnose ACTH independent Cushing. For example, in the woman that has adenocarcinoma, her ACTH was 2.5, less than 2.5, and her serum cortisol was 13 or 14. That's when we suspect that she had an adrenal lesion. And measurement of adrenal androgen production, DHEAS, and 24-hour urinary ketosteroid, which we don't do anymore, can confirm adrenal tumor. Pseudo-Cushing's can occur in pregnancy, depression, alcohol dependence, glucocorticoid resistance, morbid obesity, poorly controlled diabetes, physical stress, malnutrition, intense chronic exercise, hypothalamic amenorrhea, and CBG excess. You all know what it is. Sometimes the Endocrine Society also advocate to do the 2 milligram dexamethasone CRH test to differentiate pseudo-Cushing's from actual Cushing's. I have only done it once. So what you have to do is to give 2 milligram of dexamethasone, again 0.5 milligram every 6 hours for 48 hours. And then you give CRH at 1 microgram per kilogram IV. And then you need to do cortisol measurement for every 15 minutes for 1 hour after that. Okay. And normal response should be less than 1.4 microgram per deciliter to exclude pseudo-Cushing's. As I said, I did it only once because one patient is very obese when she came to me, and she turns out to be Cushing's disease again. So I'm going to focus on Cushing's disease rather than, the whole Cushing syndrome. We know that the normal pituitary anatomy is you have all this pituitary gland in the sella. On top of it is the optic chiasm, and you have all those cranial nerves nearby, cranial nerve 6, cranial nerve 3, 4, and you have this B1, B2, what is it? Parasympathetic and sympathetic ganglion here. So the most common cranial nerve that is affected with pituitary tumor is actually cranial nerve 3. When you have a microadenoma, according to MELMED, it's because of aneuploidy, or you have mutation or germline or somatic mutation or cell cycle dysregulation. That's why you end up with a pituitary tumor. What distinguishes microadenoma from macroadenoma are paracrine-stromal events and epigenetic changes, not actual genetic changes that will make it grow and become a macroadenoma. We really do not know what drives the changes for aggressive adenoma to occur. But we know that in terms of Cushing's disease, 90% of the patient has microadenoma. Only about 10% has macroadenoma. However, with this 90% of microadenoma, it is only detectable on MRI in about 60% of the cases. So in about 40% of the cases, you will see nothing on MRI. Despite, biochemical confirmation of Cushing's disease. That's where inferior petrosal sinus sampling come in to distinguish which side of the pituitary gland is involved in oversecretion of ACTH, and also to distinguish it from ectopic ACTH secretion. In this case, you measure the petrosal and peripheral vein ACTH level. So you measure the basal, and then 2, 3, 5, and 10 minutes after CRH infusion, you look at the ACTH level here in this side and in this side. And if you had this ratio, after CRH infusion, you can see if it's the inferior petrosal sinus sampling over peripheral vein ACTH, then if it's more than twofold, then you have pituitary Cushing's disease. If the inferior petrosal sinus ACTH and the peripheral vein ratio is less than 2, then you have to consider ectopic Cushing syndrome. If the right versus the left ratio difference is more than 1.4, then you can lateralize it to the right or to the left. Again, they do not recommend using 8 milligram overnight dexamethasone suppression test in the latest consensus, but I still do it. It's just for my peace of mind that this is not an ectopic ACTH secreting tumor. But you can also use 48-hour high dose, meaning 2 milligram every 6 hours. And test to differentiate pituitary from ectopic ACTH, because ectopic ACTH will not be suppressed by dexamethasone. Okay, so the general scenario of treatment is we send the patient for transsphenoidal pituitary surgery. And then if they're cured, the patient go into endocrine remission. If they're not cured after surgery, then many neurosurgeons want to repeat the transsphenoidal pituitary surgery. This time, it's more extensive surgery. They usually do hypophysectomy or take out the whole anterior pituitary gland. And if it's still not cured, then you have to consider this other treatment, radiation therapy to the sella, while giving medical treatment, or at worst, you have to do bilateral adrenalectomy. So, transsphenoidal pituitary surgery is a first-line treatment. Of course, there are contraindications to the surgery. If you need continuous anticoagulation for any reason, if the patient declines surgery or has active sinusitis or is psychotic, they should not have the surgery. In terms of the determinants of post-op remission, if the next day after surgery they have very low morning serum cortisol, meaning less than 2 microgram per deciliter, then more likely they are in remission. Some people would support it by doing 24-hour urine free cortisol measurement and late night salivary cortisol after the initial pituitary surgery. The TSA, transsphenoidal surgery, achieved biochemical remission in up to 90% of microadenomas and 65% of patients with macroadenomas. What makes it more likely to go to remission is if the neurosurgeon see the tumor and can visualize the tumor during surgery, then more likely the patient will go into the remission. If the pathologist did a stain and the cells that the tissue they got is positive for ACTH staining, then it's more likely that the patient will go into remission. It does not matter for microadenoma, but use of endoscope increase the chances of remission in macroadenomas, but not microadenoma. In terms of histopathology report, if the specimen stained for ACTH and the surgeon is sure that he did a complete resection, and if they do not stain for Crook cells. What's Crook cells? Crook cells are not non-neoplastic cells. These are the corticotroph that are very large and stain for hyaline a lot. It means that they have a lot of cytokeratin. And that only happens if they were exposed to a lot of dexamethasone, steroid. So, if there are Crook cells, it's more likely that the patient will not go into remission. And also the Ki-67 counting, if it's less than 3%, more likely the patient will not have recurrence. If the Ki-65 counting is more than 3%, they're more likely to recur. We're not talking about, initial post-op remission, but recurrence later on. The complications involved epistaxis, like what this patient had, tumor bed hemorrhage, CSF leak, meningitis, venous thromboembolism, transient or persistent diabetes insipidus, hyponatremia. Most of it is caused by SIADH. This is probably, Dr. Mukshagandam, what happened to the first patient who's now in the hospital with serum sodium of 120. She came to me 4 days after surgery discharge, and I took her off desmopressin tablet already because her sodium was trending low already, and she's asymptomatic. Well, she probably went into SIADH, phase. And anterior hypopituitarism can occur in 2 to 40% of the patients. So this is the study by Lynette Niemann from NIH showing what post-op AM cortisol means in terms of biochemical remission. They did morning cortisol on day 3, day 4, and day 5 after pituitary surgery. And they found that if it's less than 2 microgram per deciliter, the remission rate is higher compared to if it is between 2 to 4.5 microgram per deciliter. So, in this study, it's not actually very clear-cut. About 9% of patients go into remission if their morning cortisol are less than 2. And about 20% of patients is it positive remission, negative remission? About 20% of the patients here did not go into remission when their morning cortisol is between 2 to 4.9. So this is about 9% of patients that did not go into remission when their serum cortisol in the morning was less than 2. They also did a CRH stimulation test and found that the people who with morning cortisol of less than 2 microgram, when they did the CRH stimulation, the ACTH and the cortisol level did not go as high as the people who had morning cortisol between 2 to 4.5. So many neurosurgeons will do the second pituitary surgery if the morning cortisol is completely normal, like, above 5, and they want to do the repeat surgery after a few weeks or within 2 months of the original surgery because there is less scar and they still remember the anatomical details of the patient, and so they want to do the complete resection. And second, transsphenoidal pituitary surgery lead to 54% more remission. But as I said, it's a more extensive surgery. It's hypophysectomy. In terms of remission with recurrence, meaning within 5 years, sometimes they do recur, there's 64% remission with pituitary surgery. Of course, you all know that they need glucocorticoid replacement until their pituitary adrenal axis recover. Most of the people will just need physiologic dose of steroid, but some patients initially require supraphysiologic dose of glucocorticoid in order to alleviate glucocorticoid withdrawal symptoms. I think that's what my first patient has right now. And patients with Cushing's disease would require lifelong periodic surveillance to detect recurrence of hypercortisolism, but most of the recurrence occur within the first 5 years. And the recurrence rate is 2% of patients per year. It peaks in the first 5 years after tumor resection, but it may also occur a decade or longer later. The cumulative risk for recurrence is actually very high. If you do 30 to 50-year follow-up, it's 30% in long-term follow-up. Of course, macroadenomas are more likely to recur, and people who require glucocorticoid replacement for less than 12 months are likely at a higher risk for recurrence. And patients with normal rather than low morning serum cortisol in the early postoperative periods are at higher risk for recurrence. It makes sense. And to detect for recurrence, it's better to use the salivary late-night cortisol measurement because they're more sensitive than using the 1 milligram dexamethasone suppression test or urinary free cortisol measurement. If the patient does not go into biochemical remission, an alternative is to go for radiation therapy. There are two types of radiation therapy, conventional and stereotactic radiosurgery. The only difference here, they're both stereotactic now, meaning it's a three-dimensional mapping that's done before they give the radiotherapy. One of my patients does this as a, livelihood. She goes through CT scan and MRI and map everything so that the radiation oncologist can give the radiation in that area that she specifically mapped, Anyway, for conventional treatment, it's usually 20 to 30 sessions. Of course, it's fractionated. That's why you need 20 to 30 sessions. The remission rate is 68%, a wide range, with mean time to remission of 15 to 24 months. And 38% of patients develop new hypopituitarism. In terms of stereotactic radiosurgery, the only difference is you do it in one session versus 20 to 30 sessions with conventional treatment. It's also stereotactic. You either use gamma knife or linear accelerator and cyber knife. Gamma knife is you use gamma rays from cobalt source. The remission rate with gamma knife is 66%. Mean time to remission is 17 months. So it's exactly like what happened with conventional treatment. In terms of using linear accelerator or cyber knife, you use the heavy particles like protons to bombard the area. With the use of proton, the remission rate is 66%. Mean time to remission is 22 months. And with the use of linear accelerator, remission rate is just 46%. Mean time is 24 months. So even though you use one treatment, high voltage treatment, etc., the remission rate are comparable to conventional treatment, and it takes similar time. It takes 1 or 2 years before you get the complete effect of the treatment. The third option is medical treatment. You usually give medical treatment while waiting for the 1 to 2 years that it takes for the radiation to work. Of course, our favorite, ketoconazole, block multiple steps of the biosynthetic pathway for steroid and mineralocorticoid. So it affects the 22 desmolase, 11 beta hydroxylase, and 18 hydroxylase. So if you block most of it, this pathway, in men, you can get hypogonadism by inhibition of gonadal steroidogenesis. So the next one is methyropon, which is a potent inhibitor of 11 beta hydroxylase and 18 hydroxylase. It will decrease serum cortisol and aldosterone and increase the androgen, so leading to hirsutism and hypertension. Hirsutism because of the androgen. Hypertension is because you block this pathway, therefore you accumulate 11-deoxycorticosterone, which can, lead to hypertension. Mitotane is an adrenolytic agent, but you can use low dose to block this pathway and also block 18 and 11 hydroxylates, 11 and 18 hydroxylase enzyme. Etomidate has to be given IV. It's a potent 11 beta hydroxylase inhibitor, and it should be limited to ICU use. Of course, mifepristone, this is the only one that I have more experience in a total of 3 patients. Okay, you get improvement in hyperglycemia in 60% of the diabetic patients. You decrease blood pressure by 38% of the patient, but it is now approved for global use in Cushing's disease. So you don't have to have diabetes or hypertension. As long as you have the diagnosis of Cushing's, you can now use mifepristone. The newer kid on the block are osilodrostat. This was originally being developed for hypertension. It was a potent inhibitor of aldosterone synthase, but it has been shown to block 11 beta hydroxylase as well. So it's now it's in phase 3 clinical trial for Cushing's disease. The next one is levoketoconazole. So this is, turns out that ketoconazole is a 50 to 50% racemic mixture of 2S4R and 2R4S enantiomer. Remember in your chemistry, the right and the left, enantiomer, okay? It turns out that levoketoconazole only had this enantiomer, 2S4R enantiomer, which made it less hepatotoxic compared to ketoconazole. So it inhibits, again, like ketoconazole, 11 beta hydroxylase, 17 and 21 beta hydroxylase. So it's more potent than ketoconazole. Again, phase 2, phase 3 of clinical trial. Aside from the medications that are targeted towards steroid production, there is also a bunch of medications that's targeted towards the pituitary gland. Cabergoline, sometimes you need pretty high dose, up to 7 milligram, and it can normalize urine-free cortisol in 40% of the cases, and you all know about the side effects. Pasireotide and pasireotide LAR are the only ones that are specifically approved for Cushing's disease, not lanreotide or octreotide, So these are the dosing. Temozolomide is a DNA alkylating agent, so it's like any chemotherapy. You do get partial or complete tumor response in up to 80% of the cases. This one is usually used for other brain tumor, including glioblastoma, etc. There are many other products that are in development phase, including ACTH neutralizing antibody, EGFR targeted therapy, and a lot of the cyclin-dependent kinases that are targeted, including retinoic acid that can bind to the receptor. So these are the medications that are being developed for future use. Of course, after you do the the initial workup and you confirm it with measurement of ACTH, you have to consider all the other metabolic component of Cushing's disease in terms of treatment. Again, the schema is usually you do transsphenoidal pituitary surgery, and if there is a remission, you just do active surveillance. If there is persistence of the Cushing's disease, meaning the AM cortisol is high, they may require immediate second transsphenoidal surgery, this time hypophyseectomy. But you have to assess the comorbidities associated with Cushing's disease. That's our role, actually, as an endocrinologist. And if there is a recurrence or there's no remission, you have to consider medical treatment in addition to bilateral adrenalectomy, radiotherapy. So what are the comorbidities that you need to consider when you're treating a Cushing's patient? Of course, pituitary hormone deficiency, so replace hydrocortisone, thyroxine, gonadal steroids, growth hormone, I don't know about growth hormone, and desmopressin if it's needed. If the patient has diabetes, the mifepristone and cabergoline has been shown to improve glucose tolerance, but pasireotide can deteriorate glucose tolerance by reducing insulin and incretin secretion. So you need to treat them with metformin, DPP-4 inhibitors, and GLP-1R agonists or insulin. If they have dyslipidemia, mitotane can increase LDL and HDL. It is a potent cytochrome 3A4 metabolic activator, so you should use rosuvastatin and pravastatin, but not Lipitor and simvastatin. If they have high blood pressure, you need to use angiotensin type 1 receptor antagonist or angiotensin receptor blocker, or add spironolactone or eplerenone when hypokalemia exists, or use calcium channel blocker. If the medical treatment that you're using are 11 beta-hydroxylase inhibitors like methyropon and oscillodrostat, what will happen is you will accumulate the 11-deoxycorticosteroid. So your blood pressure will get worse by increasing cortisol and aldosterone precursors with mineralocorticoid activity. Again, it's mostly 11-deoxycorticosterone. If you use cabergoline and apaceriotide, these two has been shown to improve blood pressure control. In mifepristone treated patient, hypertension and hypokalemia do get worse because you block the receptor, glucocorticoid receptor. What will happen is you will have increased serum cortisol level that will saturate the 11-beta-hydroxy dehydrogenase type 2 enzyme and activate mineralocorticoid receptor. So all this medical treatment, you have to consider the metabolic consequence in terms of Cushing's disease. Of course, there are other risks that we have to consider. It is recommended that if the patient is severely Cushingoid, you have to do routine antithrombotic prophylaxis, especially when they're immobilized, or you need to do immediately post-op. The risk for thromboembolic disease can last up to 3 months after pituitary or adrenal surgery. In terms of prophylaxis, patient who had severely Cushingoid disease has to have prophylaxis with trimethoprim, trimethoprim for pneumocystis jirovecii infection. Never heard of it. And you have to give the usual vaccination against flu, herpes zoster, and pneumococcus. In patients with osteoporosis, if they are younger and premenopausal, all you need is calcium and vitamin D supplementation. But if they have severe bone damage or have hip or vertebral fracture, or those older than 70 years old, it would require active therapy with bisphosphonate, teriparatide, or denosumab. Oh, it's past 4. I'm finished. In terms of prognosis, this is an article published by Dr. Melmid. We know that corticotropin-secreting tumor are not that common. The more common are prolactin and the null one, the one non-secretory, pituitary adenoma, followed by growth hormone, acromegaly, then Cushing syndrome. Much less common is the thyrotropin secreting tumor, or LH or FSH secreting tumor that are actually functional. The non-secretory one have silent gonadotrope, etc. In general, in terms of pituitary adenoma management, if the patient is less than 30 years old, they usually have more aggressive growth and recurrence, and they usually have more florid hormone phenotype, typical with acromegaly. If they're over 60 years old, the tumor tends to be less aggressive and tends to be smaller for growth acromegaly, but still larger for prolactin-secreting tumor. Females tend to have more prolactinoma and Cushing's, and males tend to have more macroadenoma, especially prolactinoma. So they also go through whether the patient has dense granule or sparse granules, and if it's a dense granule, so sort of like more differentiated, and they're more indolent in course. If it's sparsely granulated tumor, they tend to be more resistant to treatment and more aggressive. And as I mentioned before, Ki67 cell cycle marker, which the pathologists normally put in their pathology report, if recurrence is less likely if it's less than 3%, and more likely if it's more than 3%. I think that ends the talk right now. So, any questions about Cushing's disease? Anybody can hear me?
Yeah, we can hear you. Thanks.
All right, well, maybe a question, a comment and a question, Betty. So
Okay.
the reason that the dexamethasone suppression test is not so helpful with ectopic Cushing's is that the ectopic is a very heterogeneous disorder, and that traditionally it's the people with lung cancer who lose weight and hyperpigmented and hypokalemic and diabetes, but that's a minority. The majority of them have neuroendocrine or carcinoid tumors, which are in the lung, the thymus, the thyroid, the pancreas, and all of those look clinically just like pituitary Cushing's, and they all respond to dexamethasone, just like pituitary Cushing's.
Oh, so they do respond to dexamethasone. Okay.
So that some ectopics respond to dexamethasone with suppression, and some don't. So that's why it's not helpful, really, to do that kind of test.
Okay.
So what they recommend is the petrosal sinus sampling, and then look around with scans if it looks like it's ectopic to try to find where the tumor might be.
Okay. Yes, that's very helpful, because 40% of the patients do not have a definite tumor in their pituitary.
That's right.
Yeah.
So then my question is about the pseudo-Cushing's versus the Cushing's and you said that a dexamethasone suppression test is helpful.
Followed by CRH.
Well, but you said dexamethasone alone. So I wondered about the reference to that, because I've never read that.
I think it's more, some people would require the low-dose dexamethasone suppression test to diagnose Cushing's at all. But the 2 milligram dexamethasone suppression test with CRH after day 2 is the one that's really used by Endocrine Society to distinguish between pseudo-Cushing's and Cushing's.
Yeah, that's what I thought.
So yeah, so the 2 milligram is really just for Cushing diagnosis. Yeah. Any other question? Everybody's sleeping. Sorry, I talked too long. But this is relevant.
Nice.
Now, this first patient is now back in the hospital with serum sodium of 120. Dr. Muksha Gandum just told me. Probably going through SIADH phase already and did not stop over drinking, because I took her off the ABP when she came to me for initial visit. Yeah.
So my guess is she's going to go on to have DI.
She did have. Yeah, she had, she may go to permanent DI. And her morning cortisol is not good either. According to Muksha Gandum, it's 4 microgram per deciliter. So not very, very good for remission. 20% chances of not going into remission. I mean, she saw endocrinologist for 3 years, She just did not mention her big abdomen until she came to me and said, "Look at me." But the second one, who's that other surgeon aside from Amy Quillo, Dr.
Edgar's this thing. Eggers is
Huh?
the one who's doing Eggers,
Yeah,
Mike
Egger
Eggers.
is Egger is
Hmm?
the one that I refer her to
Yeah.
for the adenocarcinoma.
Hmm.
So I talked with him, and he said he wants a CT scan of the chest. She's going to be seen this Friday, so
Hmm.
that by next week she can have her adrenalectomy. Hopefully, it's not metastatic.
Yeah.
Lovely, lovely lady, you know. She's just crying her heart out right now, you know. Okay, but
Okay.
here
Thank you
in
very
the
much.
private clinic, you do the workup within 1 week. All the
Yeah.
patients are so compliant,
They
Yeah.
don't have to travel much. They can come there easily.
No, they just